Pradeep Pendyala, Professor of Anesthesiology. Today I am going to talk about the basics of myocardial infarction, and what you should know the recent advances, very basics. And as an anesthesiologist or a physician or a person who takes care of critical care, what are the basics you should know? Everybody knows that myocardial infarction is nothing but myocyte necrosis, and there could be an increase of cardiac troponin, CTN, with at least one CTN measurement greater than 99 percentile of the upper normal reference limit. And the symptoms of myocardial ischemia would be there, and ECG changes would be there for MI, that is ST segment elevation or T wave changes, or they could be left bundle branch blockage. The development of pathological Q waves also would be there, and there would be definitely regional wall motion abnormality in the echo. I'm sure you all know. And the routine usage of antiplatelet drugs like clopidogrel, prasugrel, or ticagrelor is being given in addition to the aspirin. That reduces patient morbidity as well as the mortality. And I'm sure you know about the PCI, percutaneous coronary intervention, in a timely manner, especially given in a case of acute STMI elevation, is life-saving. And drug-eluting coronary stents are definitely safe and beneficial and during coronary intervention. And what are the changes in the ECG? The thing like ST elevation of more than 0.5 millivolts in AVR, in acute left main coronary artery obstruction, and proximal left anterior descending coronary artery obstruction has to be noticed in obstruction proximal to the major septal branch. The ST elevation in AVR is more pronounced than V1 in patients with acute left main coronary artery obstruction. This you should be aware of. The ST elevation in the AVR is usually more pronounced than V1 in patients with left main coronary artery obstruction. One of the most important things about STMI management in patients, to get the patient to the hospital as early as possible and administering reperfusion therapies such as fibrinolytic therapy and primary percutaneous coronary intervention, that is PCI. When PCI is not available in the hospital, fibrinolytic therapy is definitely the alternative. It reduces mortality and morbidity, especially if it is administered before 12 hours of symptoms of MI. The role of aspirin and clopidogrel with fibrinolytic therapy is known and well established. Aspirin and clopidogrel should be given prior to the fibrinolytic therapy. Now, dual antiplatelet therapy should be continued at least for 1 year, minimum 6 months, and preferably for 1 year. Talking about prasugrel and ticagrelor, the fibrinolytic therapy effects are not very well established. In addition to these fibrinolytic agents, adjuncting anticoagulants should be administered, and unfractionated heparin, enoxaparin, fondaparinux could be used in this aspect. Low molecular weight heparins should be avoided. especially if the patient has renal function impairment, which could be known by decreased creatinine clearance, which is less than 30 ml per minute. Thanks for patient listening. This is absolutely basics of management of MI. I hope those people who have forgotten about it might be helped by this small talk. Have a wonderful day. I'm signing off for today. Take care. Bye bye.